Good afternoon, everybody. This is the second part of immune-related anterior segment eye diseases. You had the last week a lecture by Dr. Turki who spoke to you regarding peripheral ulcerative keratitis, which is sort of the same spectrum of the diseases with different location. Today we'll speak mainly about scleritis and Episcleritis. And we have the honor of having Dr. Mohammed Al-Umair. He's the consultant rheumatologist in King Khalid Hospital. And he will share with us definitely his tremendous experience in dealing with immune diseases. And we will speak regarding some of the new modality in immunosuppression and the treatment of those patients. طبعا as you all of you know, my usual lectures are sort of discussion and will interrupt every now and then. The first half we will speak about more of studies and certain knowledge, and in the second half we'll present some cases and they will ask most of you to share and give me your opinion and thought about the treatment and diagnosis. Okay, scleritis. When you are talking about scleritis, we meant to discuss the inflammation in the sclera or the tissue adjacent to it. And most of the time, either you will have the primary disease in the sclera, and you will call it primary scleritis, or it will be a secondary event that happen to secondary to other inflammation in other part of the eye. Sometimes pan-uveitis or even infectious causes can cause secondary scleritis. Another example is myositis, secondary to thyroid eye disease, may affect also the sclera, and you have the secondary scleritis. But both of these entities are sharing the same, most of the time, same symptoms and signs and relatively the same presentation. طبعا when we are talking about the sclera and the blood vessels around the sclera, you need to differentiate between the blood vessels coming from the conjunctiva and the blood vessels just above the sclera and the scleral blood vessels. And in every disease, you will sort of classify the entity based on the engorgement and the primary site of inflammation. But there is no clear defined margin between scleritis and episcleritis. Like there are some suggestive signs that will guide you to diagnose any one of them. طبعا as maybe Dr. Turki discussed to you last week, the area which is the limbus, the junction between the cornea and the sclera, is having the most of the vascularization and most of the immune event happen at that area. So in the pathophysiology or immunopathology of the scleritis, it is rarely to inoculate eye with scleritis, but in the inoculated eye, they found that the necrotizing scleritis showed area of vasculitis and fibrinoid necrosis, and there is a tremendous invasion of the T cells, mainly with HLA-DR expression, and these will guide you even in the treatment and management of subsequent treatment for those patients. So you will target these immune action, and then you can suppress the inflammation. So in classification of the scleritis, we usually classify them according to the etiology or in the site of the inflammation, and both of them are well taken classification, and both of them will guide you in terms of the diagnosis and the treatment. So the first one, which is the autoimmune system associated, and this is usually the common associated diseases. Rheumatoid arthritis is the top, Wegener granulomatosis, relapsing polychondritis, systemic lupus erythematosus, and polyarthritis nodosa. And all these have certain specific features to enhance your diagnosis, but the key to reach these diagnoses is to have complete medical history. Without complete medical history, you will not be able to elicit any of the signs suggestive of the diseases, plus that you need to think and put it in your mind. If you have patients with scleritis or eye manifestation, you need to dig in the history and ask specific questions about these diseases, such as Abdurrahman, and you have patient with rheumatoid arthritis, Abdurrahman Belushi. What are the things that you will ask specifically the patient? Mm-hmm. What is more specific other than the pain and the joint pain? Okay, so the stiffness is something you need to ask specific about that. For some patients, they will not volunteer to you the diagnosis. You need to ask them in specific. You say, okay, I'm having general pain on and off, but you need to ask specific. Like the ankylosing spondylitis, you need to ask in specific the back pain when it is coming in the morning, or and vice versa. Do you have any comment, Dr. Mohammed?
Bismillahirrahmanirrahim. Thank you for inviting me. Now, I think the collaboration between rheumatology and ophthalmology is very important to treat diseases that affect the eye, and as mentioned, the history is a key component, because if you look at the list here, most of these diseases can have a negative serology. So rheumatoid arthritis can have a negative serology in 25%, Wegener gammatosis in 15%, relapsing polychondritis is negative. The only one that has or should have a positive serology is lupus, and usually they have ANA and might have other autoantibodies. Polyarthritis nodosa is also negative serology. So history and examination are really important. And for example, like when we talk about rheumatoid arthritis, now I hope that I will never see a skin nodule ever in my life, because, for example, skin nodules are not seen anymore, because patients are diagnosed early, treated early, and disease control. People who had long-standing rheumatoid arthritis before the biological era, these are the ones who used to develop nodules. But as mentioned, they are like key features, which rheumatoid arthritis, psoriatic arthritis, Behçet disease, any of these have this inflammatory joint pain, which is worse in the morning, improve with activity or improve with exercise, get worse with resting. So if the patient takes a nap for an hour, he gets back the pain, which we call the gelling phenomena, and they might have nocturnal pain. So people with osteoarthritis, they don't wake up because of pain in their hands. But people with RA, they can wake up with pain in their hands. Similarly, inflammatory back pain in patients with spondyloarthritis. And I prefer the word spondyloarthritis because it's more general. Ankylosing is a more specific and typical disease. And you go with the others, Wegener gammatosis, which usually have recurrent ear infection, recurrent sinusitis, which is again not a very classic, not a very specific symptom, which occur in many people. So having the whole picture will lead you to what needs to be ruled out or diagnosed.
Okay, excellent. Thank you, Dr. Mohammed. So these are need to be ruled out. In diagnosis. So the importance of such or occult systemic autoimmune disease should not be underestimated in patients with scleritis. Even in the when you diagnose the patient as idiopathic to start with, and then in the subsequent follow-up, sometimes you need to visit back your investigations and history and do it again, because some of them they will manifest later on. Okay. The other type is the infectious causes, which is an important causes of scleritis and need to be ruled out before initiating any treatment and before reaching to any conclusion with the treatment or with the diagnosis. So infectious scleritis, and those are the organisms that can cause infectious scleritis. TB in our area is a known cause of scleritis, syphilis, another cause. Sometimes acanthamoeba or herpetic, even in specific, they may be presented as infectious scleritis. If you have patient post-traumatic or post-surgical, especially post-regium, the report shows that the most common organism in those patients is Pseudomonas. So we know Pseudomonas is a bad organism and need to be diagnosed earlier to have the good outcome. It's the same, we're talking about the cornea, the same in the sclera. So you need to take the same panel of test of having culture and sensitivity and send it to get the diagnosis. Okay, so it is almost 5 to 10% of those patients, they may have infectious scleritis. And we will talk about this in brief when we talk about the scleritis in Saudi Arabia. The other thing that need not to be forgotten is the masquerade. Something like melanoma or lymphoma can mimic scleritis, and also these are difficult to diagnose, but you need to keep it in your mind. Surgically induced scleritis, it could be an infectious, sometimes is an autoimmune, but in both cases, you need to take a culture and deal with it as infectious until you rule it out. So the diagnosis will be with the culture. If not, maybe you need to take a biopsy to rule out any infectious organism. Other causes of scleritis, maybe trauma, nodular scleritis, or drug-induced. These are rare, but also classified as an etiology for scleritis. These are These are two pictures of two patients that I had. Faisal, why not? Can you please comment in the first picture? Yes. بس ارفع صوتك، أعتقد صوتك يعني.
Mainly at the temporal side. Corneal is normal, lateral.
Those are two patients, بالمناسبة. But I just want to show you the difference between them. I couldn't. Sorry, Faisal, sorry for. Yeah, welcome. I think this is the voice from Dr. Ishraq from Medina. I would like to welcome all of the people joining us now from other programs. We are talking about scleritis and episcleritis, immune-related disease, and we have the honor of having Dr. Muhammad Umair from King Khalid University Hospital, who is the consultant rheumatologist. He will comment also about some of these diseases and the treatment. ما اشتغل يا فيصل؟ أنا يونيت للثاني يمكن هذا.
So the first photo showing conjunctive blood vessels with no nodule, but the second photo of the other patient showing a lesion at over the sclera, not very far from the limbus, with the vascularization beside it. It is elevated, well demarcated, and this is a stain over it, or is the natural color? I'm not sure.
This is stain after fluorescein. طيب, in your opinion, which one is more aggressive and which one you need يعني, special attention? The one in the top or the one in the bottom?
The one in the bottom with the
Why?
elevated lesion.
Why? Because it is necrotizing. It is necrotizing. And most of the time, the necrotizing one associated with bad diseases. If you have patient, sometimes it will be more extensive and sometimes it will be localized. This patient had pterygium surgery done before 2 months and presented with this. And when we took the culture of this, tend to be Pseudomonas. And in 1 week treatment, he resolved completely. We gave them oral and topical. The other one is diffuse. Mostly it is a nodular, in fact, anterior scleritis, and he responds to immunosuppression. But if you are talking about the eye, the one in the bottom is more aggressive, and if you talk about the systemic, the superior one will be more associated with systemic disease. And that one, you need to have complete exams and investigations, which we will talk about in a minute. Okay. Yes.
When you see this patients in the emergency room, especially the inferior one, so how do you tell why? From where do you say it's necrotizing? So you can see that area is devoid of the blood vessels. You see the white area, you don't see the blood vessel there. So that's why we say it's necrotizing. So it's very important to look for the blood vessel. It's not necessary to be injected. Sometimes it's injected around that area, but the white area, a bit devoid of the blood vessel because it's necrotizing. That's why we say it's a necrotizing scleritis.
Excellent, thank you. And also, when you have it, also the choroidal or the tissue under the sclera will be more obvious. So you will have thinning, and you can see discoloration. That indicates there is thinning, and you are seeing now the choroid, which is the layer behind the sclera. Okay. Now, the other classification, which is another popular classification of scleral inflammation. Episcleritis sometimes included in the classification of scleritis, sometimes is not. But it is, some people they think it is milder form scleritis, though the argument against this, it is usually not progressive to scleritis. Usually they will be nodular, and they may have repeated attack of nodular, but again it is, they have some similarity of associated with systemic diseases. The good thing about them, they are not usually progressing to scleral melting or necrosis. The classification of the scleritis, we usually classify it to anterior, and this is the Watson classification, anterior and posterior. The anterior will be classified to diffuse, nodular, and necrotizing, and the necrotizing will be with inflammation or without inflammation, and the one without inflammation, we call it scleromalacia perforans, and most of the time associated with rheumatoid arthritis. The posterior scleritis, again, it may be diffuse, nodular, rarely to be present in the posterior, or it will be scleritis, and sometimes it will be necrotizing, but most of the time the necrotizing will be anterior and may progress posteriorly. The sign, these are the ultrasound signs of scleritis that you may see in the B scan. They will be increased in the cell wall thickness, and you may see also a nodule or hypoiconic area. In the posterior one, you will have the famous T sign, which is secondary to accumulation of fluid and stretching of the optic nerve of this one, and it will be presented like T sign. This is the body of the T, and this is the shaft of it. Even with MRI, sometimes when you send the patient to MRI, they will see some suggestive signs of scleritis, again thickening of the sclera. But again, these are helpful signs, but it is not enough to give you the diagnosis. You need to lump all the things, history, exam, and investigation, so you will reach to the diagnosis. One common question, and in the clinical setting, how would you differentiate between episcleritis, conjunctivitis, and uveitis? All of them are causing redness, and all of them can present in the emergency. And how would you differentiate? Dr. Ayman?
So we can use phenylephrine to see if the blood vessels are going to blanch with phenylephrine, and this is...
but this will be the quickest or the last thing to... Tell me more, from the start. You are on call tonight, and you have a patient came to you with a redness in one eye. How would you differentiate between conjunctivitis, episcleritis, and scleritis?
History, start by history.
Okay.
So episcleritis could be unilateral, or usually unilateral. It could be bilateral, but conjunctivitis, usually bilateral.
Okay.
Symptoms of foreign body irritation, usually or mild pain in episcleritis. Conjunctivitis usually comes more with redness, burning, tearing, photophobia. Yeah, so discharge, maybe either tearing or discharge, will be associated more with conjunctivitis rather than scleritis or episcleritis. Okay. Previous history of episcleritis or similar presentation. Okay, excellent. Okay. Current history of flu goes more with conjunctivitis. Okay. So, then physical examination.
Other thing in the history can add anything? Presence of systemic, excellent. Here's something. Systemic manifestation, usually associated with immune-related, either episcleritis or scleritis. If the patient is rheumatoid, known rheumatoid arthritis, or known to be treated, or all these are, if you are not keeping it in mind, you will not ask about them. Huh? You need to keep it in mind. Okay, so then you will go to the exam. What are the things that in the exam may help you in doing? Maybe can go to Hanan.
examination, usually Episcleritis can present either as a diffuse injection or a nodular involving sectoral part of the episclera.
Okay.
The conjunctivitis is usually diffuse. We can see also discharge on examination. The uveitis, actually, it's mainly ciliary injection. It's circumcorneal only, with anterior chamber reaction and other signs of uveitis we can see, like posterior synechiae, nodules.
Yeah. What else more with the scleritis, not with the conjunctivitis and not with the uveitis? Scleritis.
The scleral edema.
Okay, this is in the exam. What else?
Tenderness.
Tenderness. So tenderness, in my opinion, is one of the important thing to elicit and ask the patient in specific. That will differentiate between scleritis and episcleritis. The tenderness is usually with scleritis, indicating the inflammation is deep and stretching these blood vessels. Whenever you touch it, patient will jump. Okay. What else? Other thing that you want to do other than the exam? But definitely you will examine the fundus. You will see if there is choroidal fold. That will be more with the scleritis. If you have inflammation, either uveitis will be as primary or secondary. So, but that will not rule out a patient with scleritis and secondary uveitis or sclerouveitis, which is known entity. Okay, what other? They were saying something about the drops, phenylephrine drop.
Phenylephrine, yeah.
What is?
Episcleritis, it will blanch with the phenylephrine. Usually in 10% they give. In scleritis, it will not blanch.
طيب الفينالفرين but it is mentioned a lot in the books, but يعني personally I don't find it يعني that helpful. It may differentiate between conjunctivitis and scleritis, especially with the percent that is available in the clinic, which is 2.5. But if you go to higher percent, which is 10%, that may differentiate between scleritis. But though it is even difficult to say only this is the sign that I will do it, I just put a drop and that will tell me, will give me a magic solution for my situation. It is something that helps. But يعني, it's not something that you put a lot of weight. يعني, I wouldn't expect from you when I say scleritis, episcleritis, conjunctivitis, okay, phenylephrine. يعني, I know it is in the book, and it is يعني, a lot of people putting a lot of weight on that. But يعني, if you want to make it, it will be the bottom يمكن في help to you in the ER. Okay. Any question? أيوة عبد الكريم. Sometimes yes, it may, especially if it is adjacent to the limbus. But if it is in the mid, it will be difficult. And in the OCT, you may see thickening there and collection of fluid, obliteration of the angle. But يعني, it will be difficult to judge. Or يعني, حتى the UBM can help. That can help, but usually in special location. Ziad. Yes. The question is, how would you differentiate between a primary uveitis and secondary uveitis? There is no clear cut to say this or this, but usually it will be a collection of signs and findings that you will lean more to one diagnosis or other. For instance, we have one patient, I will present maybe later in the discussion, that he presented mainly with the scleral involvement, and then with the delayed treatment, he went up to have +1 AC reaction. It was not so significant, the main disease in the sclera. So you will focus on where is the primary disease. And same in the scleral involvement secondary to muscle involvement, the myositis. When you see the muscle involved mainly and the edema, the whole muscle is involved, that means the myositis is the primary and the scleritis is secondary. But if you have vice versa, the sclera all edematous and inflamed and only the 1/3 of the muscle insertion is the one involved, that may help you in differentiating. Okay. So now we'll talk about management, and most of the time management will be depend on the diagnosis, based on the first slide that we mentioned. Based on the diagnosis or the impression, you will initiate your treatment. And here is a simple algorithm that if it is posterior or necrotizing or associated with systemic disease, yes or no, and then If no, that means you are dealing with a sort of mild disease. Maybe sometimes you will start with oral non-steroidal anti-inflammatory drugs. And in the books, a classical teaching that you will try 3 medications before you will jump to another treatment modality. In my opinion, usually if they will not respond to the first or the second maximum, they will not respond to your treatment. So you need to go for other treatment after that. For oral non-steroidal to work, it needs to be at least 1 week to 2 weeks to work, and you will label them as successful or failed. And you need to instruct the patient about this medication, and you take it after meals, and the side effect of this medication. Selective non-steroidals also can help in such cases, but it depends on the severity of the disease. If you have severe disease or not responding to the treatment, you will go secondary to the systemic steroid. And that will be for a short course of a steroid. In good time, you will be lucky, and especially if it is localized to the eye, that the patient will respond to the treatment and he will not have any further recurrence. The possibility are 2. Either the patient will not respond to start with, and you need to go to the 3rd line, or the patient cannot be weaned out from the steroid. Either he will have repeated recurrence, or when you reach a lower dose, he will reactivate. In both scenarios, you need to couple it with immunosuppression. Eventually, when you have a disease severe enough to need an immunosuppression, most of the time you will go back to the immunosuppression. طبعا immunosuppression has different families and different indications, and we'll talk about it in a minute. But if the patient needs, scleritis in general is a disease that needs to have oral treatment. Topical treatment is of no much of benefit. It may be an adjunct to have the systemic treatment worked, but usually it is a disease that needs systemic treatment. And don't be afraid of initiating immunosuppression in those patients, because you are dealing with potentially blinding disease, and if it is associated with systemic disease, also that will make it more important to control their inflammation. Okay. Surgically, sometimes we can use surgical intervention in certain disease, not to treat it, rather to treat the complications. You may need to do tectonic graft. Sometimes they need cataract surgery, and they have different requirement and precautions if you are operating those patients. The most important of them is not to manipulate the sclera much, so you'll not activate the inflammation. Also, you need to quieten the disease before any surgical intervention. So on tectonic or surgical, cataract or glaucoma, you need to quieten them and deal with them like what you are dealing with uveitis cases. You need to have control, immunosuppression, and less manipulation is better. Any comment on the treatment, Dr. Mohammed?
Now, it is crucial to refer patients to rheumatology whenever you are suspecting an underlying connective tissue disease, because once the systemic disease is identified, we usually take over the management, and we usually go to more advanced therapies. So to all trainees who are here, I would really advise you not to be afraid to refer to rheumatology. So if you see a patient with scleritis and you suspect that she has RA, you have to refer her. If you see a patient with Wegener, because most of these patients, they come with an internal organ, and we consider the eye an important organ. So usually we go into 2nd and 3rd line. So for example, if a patient with Behçet disease presents to you on day 1, and she has severe uveitis, I would not start her on steroid or colchicine. I might start her on steroid, colchicine, and azathioprine, maybe start even anti-TNF depending on the severity of the eye involvement. So usually what we do with our colleagues, for example, if a patient has a long nodule and he's diagnosed as Wegener, we go directly to the induction therapy, which is usually cyclophosphamide or rituximab. So my advice is whenever you suspect an underlying connective tissue disease, please do not be afraid to refer these patients in communication, because if you refer the patient to me, I'm going to see him in 6 months. If you call me and you tell me I have a patient with RA who has severe scleritis or Wegener, I'll see her the second day.
Okay, thank you, Mohammed. So, the message out of this discussion that you need to work with those patients in a teamwork. So you need to invite your rheumatologist to be on board, or the internal medicine, to evaluate and make sure that things are under control from the systemic point of view as a diagnosis to start with, and also to follow the treatment plan that you are initiating, because they may have not response, or maybe they will have problem with the dosage or the complications. So it is a teamwork, and you need to deal with those patients in a very intense manner. These are the complications: scleral thinning, corneal perforation, glaucoma, hypotony, uveitis, cataract, posterior segment inflammation can happen. All these are list of complications that may associate with scleritis. But the key in all of these is the late treatment. If you initiate the treatment earlier on time, and you manage your patient early and follow them closely, you will not end up with having most of these complications. It can be avoided based on your treatment. Back to the treatment, this is just I want to share with you one of the important multicentral studies, called the Saud systemic immunotherapy study, which is, I make it in a summary, and here we're just talking about the scleritis. You can see with the different modality of treatment, talking about 1 year control, the methotrexate was one of the good medication to control the disease. Cyclosporine, another what has associated with complications. Silcept is another good treatment to start. And in severe diseases, cyclophosphamide will be the end of the treatment. But I brought this table to you to go back and read this study. This is a multiple series of studies talking about every medication in these in specific, and which associated with other immune diseases, uveitis, intermediate, and one of them is posterior scleritis. And you can see, and they give you a guide which treatment you will start. Classically, I will start with methotrexate because of the long record of safety. The other option will be Silcept, but again, it depends on the disease itself. If you have a disease that is known to respond to certain treatment entity, like the anti-TNF, you will go to the anti-TNF immediately. This is again the mofetil in ocular inflammation. That was one of these series of papers. You can take the reference and go back and read it. This is another study done by Jab and others, showing the clinical features of patients with scleritis. You can see the diffuse anterior uveitis and the necrotizing, the bilaterality, the ocular features, how many of them associated with posterior segment inflammation in this table. As you know, the posterior scleritis is the lowest or the rare to occur among these type of scleritis. And this is a good review to read about scleritis. And if you record the reference, it will be good to read it and keep it in your references. And now we'll talk about how about our setting. Before 2 years, we did a study here in Riyadh. Dr. Mohammed Al-Bargi, he was doing this as a thesis, and me and Dr. Ashley were the co-investigator. And we looked to the scleritis cases in both KCASH and King Abdulaziz University Hospital, and that was published recently in IGO, International Journal of Ophthalmology. And we found some interesting findings, which is good to know, and to know the epidemiology of the disease in our cases. And also it was a retrospective to give you a pattern of the disease in our setting. You can see here the most common was the anterior non-necrotizing, like published another series before. The second is maybe the posterior scleritis. It's 14 cases. This can be shifted with the pattern of the referral, because you are dealing with the tertiary hospital. You may the simple cases will be managed by the physician in the area, and then if they have complication, they may be. But anyway, that was the result of the study. Here is the mean initial visual acuity, and in that the anterior non-necrotizing and was the worst to start with the band scleritis or posterior scleritis, and the last visual acuity was also linked to the entity. So the anterior necrotizing was the worst to have the last visual acuity. So that back to the picture that we showed to you, necrotizing scleritis is the bad disease to have in the eye. And the treatment option in that study, we found out oral steroid was initiated in 65%, non-steroidal was used in 40%, subconjunctival was only used in 1%, and that eventually will change with the literature now supporting to use sometimes subconjunctival canalog, especially in non-necrotizing entities. But again, you need to rule out infectious causes before you give subconjunctival, and usually I will use it if the patient is unilateral rather than bilateral. If you have a bilateral disease, most of the time this is a systemic associated and need to have systemic. But if you have localized unilateral disease that is not necrotizing, not associated with infectious, you may go ahead and inject them with subconjunctival steroid. Immunosuppression was also initiated in some cases. It was needed in 46%, and among them the cyclosporin A was in 13%, Cellcept was in 11%. Okay. Ocular complication of those patients was in 38 of the patient, 38%, and mostly it was cataract and glaucoma and scleral thinning, with also cystoid macular edema in 3 patients. T sign was presenting on B-scan ultrasound in 9 patients, 64% of the posterior scleritis. It is helpful sign. So in the study, we conclude that of the Saudi patient showed the visual outcome depend on the subtype of scleritis. The most common type of scleritis in patient population under investigation was anterior non-necrotizing scleritis. We also found that a greater prevalence of a female patient presented with scleritis than male patient. And based on the association between infectious scleritis and previous history of ocular surgery found in the present study, we recommend that any post-surgical cases presented with scleritis be required to undergo thorough microbiological workup to rule out the infectious etiology. Okay, now we will take some of the cases and we'll discuss them one by one, and hopefully have time. We still have 20 minutes. Okay, who want to take the first case? Hamid Seman.
63-year-old female, presented with unilateral ocular pain and headache for 1 month, treated with topical medication and no improvement. External photos of the eye shows sectoroscleral injection, mainly superior, I think superior temporal, I'm not sure. There is no signs of no signs of necrosis or nodule.
Do you see anything here that other than the injection? Yes.
There is, I think, some choroidal show.
Yeah, or you may say this is edema or hue that associated with. So, any other thing that you want to either say positive or negative in this picture? It is localized, isn't it? It's not diffuse. Even by this picture, these blood vessels here is okay.
Yeah.
And it is only localized at this area. So that will classify it to be, is it?
Sectoral, I would say nodular scleritis maybe.
Okay, so mostly it is a nodular scleritis, and it is anterior one.
Yes.
Okay, at least for now. You don't examine the fundus, but this is mostly an anterior nodular scleritis. Okay, she's having tenderness and pain. So how would you start the management? This is your exam.
Starting by the history, of course. First of all, for the local causes, is there any history of trauma, surgery, previous surgery, and
no surgical intervention, no trauma.
No trauma. Systemic-wise, onset and progression of the symptoms, bilaterality or unilateral, and if it affects vision or not. For the systemic association, I'll ask about symptoms of joint pain, stiffness, chest symptoms, hematuria, and
she's having joint pain and sometimes stiffness.
What are the joints involved? What are the
It
joints?
is knee.
Knee only?
Yes.
And the stiffness in the morning mainly?
Yes.
Okay. Other symptoms I can ask about. If there is any contact with a TB patient, for example?
No.
Uh,
It's good to ask, but it has no. Let's say that you are now reaching to something. How would you do the investigation?
Going to the investigation.
What are the things that you would request? Say that you reach the impression, then you are reaching now the plan.
Okay.
How would you plan?
For the investigation, I'll first scrape this patient, or take just rule out local infectious causes.
Scraping?
Swabbing. I would say swabbing.
None.
No?
No way will not do that. Because if it is not necrotizing, it's not opened, and the conjunctiva is covering it, most of the time you don't need to take any. Because mostly this is diffuse thing that is not localized.
Okay.
But the infectious is thing that you think about, but you don't be afraid from, and you do, unless you have a patient like this and it is having a repeated attack and it's not responding to immunosuppression, then maybe there is something occult infection there. You may go ahead and take more of a biopsy rather than a swab or culture. But in most of the time, we don't do that. We just go immediately to the systemic investigations.
For infectious causes, I'll do BBD and chest CT and VDR or CS.
CT, in this case, usually will not do. It's expensive and too much radiation, which is not needed. If TB is there, based on the history that you are saying, exposure or history of, you may do it. Like just to rule out, I would go with the chest X-ray. That will be enough, and that will help both. Yani, if you want to start treatment, and maybe we'll listen to Dr. Mohammed in that point. Do we need to do that in all patients or no? And then what other investigation?
Rheumatoid factor, anti-double-stranded DNA and ANA, also C-ANCA and B-ANCA.
Okay. Okay.
Those are for that. Yeah, and also CBC and ESR to rule out systemic infection.
Okay. Dr. Mohammed, comment?
Now, whenever you want to evaluate rheumatoid arthritis, please remember that there are two available autoantibodies: rheumatoid factor, which is the old one, not very specific but still useful, and the fairly new one, which is the CCP, anti-CCP. Anti-CCP is more sensitive and specific than rheumatoid factor. So
is it available in all hospitals? Is it expensive?
Yes, it is. No, forget about cost.
No, but cost is something.
احنا المبدرين ترى فكرة في الميديسين المبدرين. Cyclosporine peptide is available in most of the hospitals, and it takes like 2 to 3 days to have the result, and it's more sensitive and specific than the rheumatoid factor.
How about the thing that's mentioned by Dr. Hamda, anti-double strand,
Yes,
all this?
and remember that yet you have 25% of RA patients who are seronegative, and despite that they are seronegative, they still have systemic manifestations. So negative rheumatoid factor and CCP does not rule out rheumatoid arthritis. Now, of lupus, the appropriate lupus workup is ANA, double-strand DNA, anti-Smith, SSA, SSB. You have to request these 5. Requesting only ANA, double-strand DNA does not mean anything, because double-strand DNA is specific, but it's not sensitive because 40% of lupus patients have a negative double-strand DNA. Now, 95 to 99, let's say, I don't believe really in lupus, and ANA negative lupus, but let's assume that it's still there. ANA is almost always positive. But you know, ANA is, again, not very specific. Yeah, normal people have a positive ANA. People with different inflammatory disease have a positive ANA. But if you have a double-strand DNA and someone has anything else related to lupus, the probability of having lupus is high. The other specific antibody is Smith, anti-Smith. And again, it's not very sensitive. About 40% of patients have a negative Smith. Complement is also helpful, but it's usually low in patients with renal disease. I advise you to request the autoantibodies based on your clinical suspicion.
Okay, and if you don't know, or if let's say with this investigation it came to be negative and you're still in the dilemma of having a systemic disease, it's still you need to rule it out by consulting the internal medicine.
Definitely, yes.
Okay, let's say that you want to treat now, maybe Mohammed Smari, you want to treat this patient. Let's say you did all this investigation tend to be negative, and you refer him to Dr. Mohammed, and Dr. Mohammed says negative, nothing. So now you want to treat.
We'll start with a topical, or start with oral non-steroidal.
Okay.
No systemic involvement, no posterior uveitis, no posterior scleritis. So oral non-steroidal anti-inflammatory drugs could be
such as
ibuprofen or
how frequent dose?
600 milligram TID.
Okay, that is reasonable to start. What are the instructions to the patient? Before meal, after meal, morning?
After meal.
Okay.
Should not be taken with empty stomach.
Yeah, because this may cause. But let's say no, he came back to you in 2 weeks' time and there is no response.
I may repeat again or to start with the systemic steroid.
Okay, so you have the option to start another one. Usually we do. Maybe it will be a selective one. And then you may initiate the steroid. What dose of steroid? .5 to 1 milligram per kg. Okay, if he is 60 kg, you will give up to 60 and we give 30 based on the disease severity. And then you will taper it over 5 days. If the patient reached 10 milligram and there is no response, or the patient has recurrence again,
we may shift to immunosuppressant drugs.
what medication you will?
Methotrexate.
Methotrexate is a good option. Do you know the dose?
No.
We usually give 15 milligram per week, weekly, huh? And you need to give couple it with what?
Folic acid.
Yeah. How would you follow those patients?
Every 3 months.
Yeah, investigation-wise, what are the complications? Instead of saying what's the complication, how would you follow them?
Follow up depends on the side effects of the methotrexate. So I will follow with the CBC every 3 months.
Okay, so CBC is important. Huh? Dr. Mohammed?
Let me give you some hints. There was a fan club for methotrexate. That would be the biggest fan. Now, methotrexate is an important drug in many autoimmune diseases. And I just give you some hints that are really practical. First, I really respect that you said starting with 15 milligram because I struggled to convince some colleagues to start more than 10, but they still start 10. Like, this is a 36-year-old female, okay? And most likely she does not have any comorbidities. So starting from 15 and increasing to 20 is actually very reasonable. But you can go up to 25 in many of the diseases. Now, for folic acid, there are different schools, and there is no right or wrong. So for example, if you go and ask Prof. Abdurrahman Arfaj or the senior rheumatologist, they give folic acid 10 milligram weekly or 5 milligram weekly. Now, I was trained in a way that if you give more folic acid, you avoid the side effects of methotrexate, including nausea, vomiting, mucositis, and this kind of tiredness that occur with methotrexate. So if you have no problem, give folic acid 5 milligram daily or at least 1 milligram daily. But if you give 10 milligram once a week, it's fine. Now, some people say that you give folic acid every day except the day of methotrexate. This is not true and does not have any evidence because methotrexate has a very long half-life. And when you give methotrexate, it's not because of its anti-folate effect. When you give methotrexate for any inflammatory condition, because of its polyglutamate action that has the strongest anti-inflammatory effect on cells. So doesn't matter to give folic acid on the day of methotrexate. Now, if patients are intolerant to oral methotrexate, this happens a lot, you have two options. Either splitting the dose, and we have good data on rheumatoid arthritis. So if someone is on 20 milligram, you tell him to take 4 tablets after lunch and 4 tablets after dinner, okay? Which even increases the level of methotrexate because 75% of methotrexate is only absorbed. The second option, I'm not sure if in this hospital it's available, is sub-Q methotrexate. It's an excellent option. It decreases the risk of GI symptoms and it has a better efficacy in our rheumatoid arthritis data.
Yeah, and that one is also helpful in pediatric age. I think subcutaneous is good. And also keep in mind that methotrexate will need time to work. It will not work immediately. So you need to couple it with steroids, especially in active, and then you taper the steroid and continue methotrexate. This is a long treatment and need to be continued for a while. Yes, Dr. Greitz, thank you for attending. Please.
I was just going to say that, although I certainly agree with the dosing you're talking about and the necessity of having enough medicine there, scleritis patients, in my experience, most of them actually respond to lower doses. So although I certainly have to push up to higher doses in some scleritis patients, a lot of them actually will respond to like 10 milligrams, 12.5 milligrams of methotrexate a week.
Mm-hmm.
So, I have no hesitancy at starting at 15 or higher with my uveitis patients. Scleritis patients, I kind of see how they've been doing and think about maybe starting a lower dose. Just to...
Yeah, that's good thought. In fact, I have one patient, this patient, no, the other one, the one I'm presenting. I was starting him, he was a bit good builder, and I started him with 15, and he responded well. And he was starting to have these complications. He just want to wean him after 1 year. When I reduced it to 12.5, was fine, and when I reached 10, he have a recurrence again. But again, it is something that you can struggle around. Yes, Dr. Hassan, please.
Yeah,
thank you for coming.
That's good, Dr. Abdullah, that you mentioned the methotrexate. I think methotrexate is underused in the uveitis per se. It's one of the good medications. It's could be used by patient once per week, while the other they need multiple of pills to be taking. The other things that this medication could be used for double use for the inflammations and even though for anti-cancers in higher doses. So I think so we need. Nowadays we don't know who is the effective medication in uveitis. We don't know. Is it the Imuran, the Celsip, the methotrexate? And by the time being there is a big trials to see which one of the medication is better to be used in the future. Is it, for example, the methotrexate or even though like Celsip or Imuran? And this is randomized clinical double masked, and based on this result we can know which medication of immunosuppressive that could be helping our patients.
Thank you, Dr. Hassan. I think for the interest of time, maybe you'll not be able to discuss. Just I'll mention to you some of these cases. This is a patient post-retina surgery and tend to have necrotizing scleritis at the sclerotomy site. And again, it tend to be pseudomonas. Give her oral ceftazidime with the subconjunctival and respond nicely, and we save the eye. This is a patient that I showed you a while ago with the post-pterygium, and the other one with the nodular scleritis. This is the one I was telling that we started him with 15 milligram, responded well, and then we reached 10, the one on the left side. This is a patient that I would share with Dr. Muhammad in treating this guy. He is a patient with Wegener granulomatosis. You can see there is maybe thinning, I don't know if it's obvious, of the sclera, and he has repeated attack of scleritis and uveitis and choroidal nodules. After treatment of rituximab, he was resolved completely, and we were able to do cataract surgery, which was uneventful. So just to present to you some cases that with different spectrum, and the treatment is different in those cases. Some cases will be managed with non-steroidals, steroids. Some of them they will reach to the rituximab, which is anti-TNF, based on the pathology of the disease and the severity of the disease. So in conclusion, scleritis is challenging disease to diagnose and to treat. When facing patient with scleritis, one should have a detailed medical and surgical history. Investigation, when needed, should be tailored according to the case. Treatment should be specific and safe, yet efficient in controlling the disease and to prevent the recurrence. So don't be hesitant in initiating the immunosuppression. And if you are afraid from the side effect or from the dose, you can seek the help of the internist, so they will help you with this. But don't be hesitant to start this medication, because these are important treatment to the eye and to the patient himself. And keep in mind, regular and close follow-up for those patients is crucial. Thank you. And if you have any question, I will have maybe 2 questions, 3. Most of the time, I will investigate, except if you have episcleritis or nodular simple scleritis. But if you have scleritis, usually you need to investigate them. Karim? Usually it is the same. Subconjunctivally is the same. No, not in this sense. Subconjunctivally. That area usually will be deficient of the conjunctiva, so we will go around it. Abdurrahman? Usually it will not change until maybe 1 week to have the response. After, the shortest will be 5 days or 1 week to shift to other. But you can say, from the severity itself, you can tell. And you can start immediately with immunosuppression or with the disease. Dr. Samir?
Thank you, Dr. Abdullah. Actually, I like your way of giving the lecture interaction between the audience. I have a comment on the phenylephrine test. Phenylephrine differentiates between conjunctival congestion and episcleral. Because the sclera itself histologically is avascular, and the vessels are only present in the episclera. Yes. So we differentiate actually not between episclera and scleritis.
Yeah, this is what usually it is of the episcleritis ones to differentiate, but usually it is not something that you will help. But still, some of the scleritis with the hue around it, it may respond to 10%, but even the response is not so helpful. But anyway, we are agree on that phenylephrine is not something that you will depend on. Muhammad, and there will be the last question.
In the setting of scleromalacia perforans, if it is inactive with a large area of uveal show and very thin sclera, would you go ahead and do a scleral patch for the patient?
As prophylactic?
Yes.
Before? No, usually you will not. And in good time, I have a couple of patients that they were responding to immunosuppression, and they will hold the progression. And whenever you stop the active inflammation, they can stay for a long time. I have a couple of patients, maybe you see them in my clinic with rheumatoid arthritis for 10 years, and they still having good visual outcome, and it is not a problem. But just ask them not to avoid the trauma.
Okay, thank you.
Thank you all.